I've been doing ringside work for quite a while. I got some training up in Colorado Springs with U.S. Olympic Training Committee. And I do have a martial arts background, which helps me understand some of the mechanisms of injury in the ring. Gentleman to my left, Richard Lord, I've known for about 20 years. If you're not from Houston, you may not know him. We graduated from University of Texas. He graduated a year after I did, and then went on to have a very successful amateur and professional boxing career, and then a very successful career as a boxing promoter. One of his most famous boxers was Jesus Chavez. That fight is actually still available. One of his fights against Floyd Mayweather Jr. is still available on YouTube, and you can see Richard in the corner with a small Matador hat on. So if you have a chance, you should check that out. All that to say, your fellow professionals ringside have a tremendous amount of experience, and as a ringside physician, I highly recommend you get to know your judges and your referees. Most of this has been covered already. TDLR regulates combative sports events in the state of Texas. The ABC functions primarily to provide unified rules of boxing and mixed martial arts. And this was mentioned before, there is a much higher rate of orthopedic injuries in MMA events. You should go to the websites, TDLR website, some interesting history about the history of regulation, boxing regulation in the state of Texas. ABC website, you can download the handbook of ringside medicine, which will give you some insight. Joint injury, watch, look, and do. Watch for mechanism of injury. We're going to look at some today: arm bars, knee bars, Kimura, and the most worrisome for me is a body slam. A lot of bad things can happen to joints with a body slam. Probably the most common one you'll see in the ring is an arm bar. Look for deformities, fracture, dislocation, and most importantly, anticipate it so that you're ready to do something. Do vascular checks and neuro checks. And you can attempt a reduction of certain dislocations, primarily shoulder and elbow, immediately. That's the best time to do it if you're comfortable doing that. If no gross deformity, palpate to localize injury, check range of motion, and do stability testing, and then triage if necessary. Know your anatomy. You should know readily how to palpate axillary brachial radial artery, lower extremity, femoral popliteal, posterior tibial, and dorsalis pedis. And you should also know some neurological anatomy and how to test for it. Brachial plexus injuries are common. That's peripheral nerve distribution, not spinal nerve dermatome, so you should probably know the difference. And most of your strength testing is going to fall into the first two categories. They're normal strength versus reduced strength to the resistance. Anything greater than that will be obvious and won't require testing. Strength testing, upper extremity, elbow flexion 5-6, wrist extension C6-7, T8, T1, OK sign, which goes for both brachial plexus and cord. A little trick about testing for strength deficit: you should always test 2 or 3 times, test to fatigue, and you'll pick up some subtle weakness. Elbow stability testing after an elbow dislocation or subluxation. A lot of these spontaneously reduce in the ring, and you may be asked to come to a corner and assess the elbow of a fighter who's having some difficulty. You should test extension, and you should test for the medial collateral ligament, do a valgus testing. I can show you how to do that later if you'd like. But that would be certainly an indication to end a fight if there's acute gross instability of an MCL following an acute subluxation of an elbow. And you should familiarize yourself with a few simple knee stability tests. Anterior-posterior drawer is fairly easy to perform. Lockman is a little more difficult. Varus valgus testing is also fairly easy to perform, a 3-point test medial and laterally. And a patellar apprehension test will pick up most of your acute instability issues. There are a lot of stability tests of the shoulder. The most important thing probably for a ringside physician is to familiarize yourself with the anatomy and be able to stabilize the scapula by palpating the acromion and palpating the ball. So there's a ball and there's a acromion. They should center. And if there is an anterior dislocation, there'll be a sulcus, and you'll be able to palpate the humeral head anterior to that arch. So that's probably the most important thing to concentrate on is the position of the ball, the humeral head, in relationship to the arch of the acromial arch. Probably the most common submission you'll see is an arm bar. This is a little more of an unusual arm bar. It's called a flying arm bar. Right about here. Boom. Elbow hyperextension, tap out. And quite often there'll be an acute subluxation relocation of the joint, so you should be aware of that. You might even consider going into the ring and assessing the elbow and making sure everything's okay. This is a good example of an arm bar with a dislocation, and this is always a posterior dislocation. The olecranon will lever the distal humerus out this way. That's what happens. Boom, goes out, and the olecranon goes to the back, and you can palpate that. And there'll be a sulcus above the olecranon, so it's I don't think it's that hard to diagnose in this situation. If you feel comfortable, this is something that will readily reduce. Check pulses, do neurovascular, and you can slip this back very easily. And if you wait, it's a lot more difficult to do it later in the emergency room 3 or 4 hours later. I've done some acute reductions. I did one actually on a professional soccer player on the field, and slipped back very quickly and easily. So if you're comfortable, this is one reduction that you can readily do and save the fighter a lot of trauma 3 or 4 hours later. And also,
what line of traction do you?
It's just longitudinal. It literally when
with the humerus.
Yes, yeah. It's just a very basically you grab the arm and very gently just longitudinal traction. Usually slips right back, and you'll also save a lot of compressive injury to nerves and vessels. So mechanism of injury, armbar hyperextension, body slam on outstretched arm. Pay attention any time an arm is out and hyperextended. Look for deformity. Differential diagnosis is going to be supracondylar humerus fracture, and I'll show you a picture of that later. There's generally angular deformity, and you can palpate the olecranon and make sure the olecranon lines up with the 2 epicondyles, and you know whether or not the olecranon is displaced or not. Do neurovascular checks, attempt reduction with longitudinal traction if dislocation, and splint and triage, fracture. If no deformity, palpate to localize injury, check for range of motion. If you suspect there's been an acute subluxation and you're checking the fighter to see if they can continue, check their extension stop, and do a medial collateral ligament stability test. Triage if necessary. This is a body slam, and hopefully something you won't ever see in the ring. Okay. This is when you start paying attention. That's a posterior dislocation of the knee. A medical emergency. Someone talked earlier about knowing who your emergency room physician is, who to call. This is not something you need to do any special evaluation on. This patient needs to be shipped. You need to notify the emergency room staff that ortho and vascular is going to need to be called up, and very high likelihood of vascular injury with the posterior dislocation. So there's something called a knee bar. You don't see it very often. It's very difficult to get in position for a knee hyperextension, and this causes an anterior dislocation. It's still a medical emergency. I don't think from a vascular standpoint it's quite as severe as a posterior dislocation. Other mechanisms of injury, body slam, and for patellar dislocation, twist, possibly a valgus blow. So obviously observe for deformity of the knee. The patellar dislocation is almost always lateral, and the knee will be held in a flexed position. This is also something you can reduce quickly and easily by simply slowly extending the knee. The patella will spontaneously reduce, and then you splint in extension and triage. Certainly, you're going to check neurovascular status on dislocations. Very rare. You probably won't ever see one. So if no deformity, palpate to localize injury, check range of motion, do stability testing, and triage. I don't think I've ever seen an acute ACL tear in the ring, or really an unstable MCL. This is a Kimura. It's a shoulder submission. The unusual thing about this particular submission is it's done in guard. Normally it's done on a side mount. There's a wrist lock to control the arm. He's trying to gain control of the forearm. Fighter mounted, doesn't want to let him have it. Once he locks the forearm and internally rotates the arm, then applies leverage to dislocate the shoulder anteriorly. Now he's got it. Applying anterior leverage to dislocate the shoulder. Tap out. As I said, normally this is done from a side mount position. There's a wrist lock on the forearm, internally rotating with leverage applied to the arm to dislocate the shoulder anteriorly. And worst case scenario is an anterior shoulder dislocation. This is another injury that you can, probably the best time to reduce it is when it immediately happens. Do neurovascular checks, and again, usually a gentle traction, maybe a little bit of internal external rotation will slip that back in. I think you've had some experience. Who's had experience reducing shoulder dislocations? Any other pearls of wisdom?
Just that I like the milch technique for the bigger, more muscular guys, because I like to use his own arm as a lever.
You want to explain that?
So just straight arms, so using the force of it, all the maximum force of his own arm, and then I'll get on the side with him on his back as I kind of walk towards the head, and I'm talking to him, feeling the elbow as I move, cephalad, move towards the head, and then just do kind of the Queen Victoria wave as he comes up. And usually right about here, it'll go back in, and they'll go, ah. And the impulse is to let go, and if you do, he'll tighten back up and a lot of times re-dislocate himself. So you got to sit there a minute, talk to him about 10 seconds, say, feels better? Yeah, all right. Now I'm gonna lay it across your chest, and then I'm gonna have you pull yourself up with your other arm, and that makes sure that he doesn't pop it back out again.
If you're comfortable, I mean, literally, the sooner you do it, the better. And if you're on the field or in a ring, and you just try it one time, just gentle reduction, gentle traction usually, and a little bit of abduction, and it'll slip right back. And the longer you wait, the muscle spasm sets in. Even from the ring to a room somewhere, there's a lot of stuff going on from a muscle spasm standpoint, and stress. And everything else sets in, so then your chances are a lot less. So mechanism of injury, Kimura, body slam. Again, you should anticipate these injuries, and subluxation. If there's been a subluxation and an acute reduction, then you'll do apprehension testing, basically a 90-90, and test for apprehension. And you can do that on a pre-fight exam as well for someone if you're worried about a history of dislocation. Do neurovascular checks, attempt reduction with longitudinal traction. And it's worth a shot. I mean, just try it once. And if not, then you ship and they can reduce it in the emergency room. If no deformity, palpate to localize injury. AC joint commonly injured, particularly in body slams, clavicle fracture. Don't forget to check your sternoclavicular joint, check range of motion, do stability testing, and strength assessment. Grade 1, you palpate the acromioclavicular joint, there'll be tenderness. If there's any deformity at all, then you're dealing with either a grade 2 or grade 3. You really can't determine the difference with a field exam or with a ring exam. Just be aware of it. The large coracoclavicular ligaments, it requires quite a bit of energy for all of those to tear, and certainly can occur with the force of a body slam. Boxer fracture, you'll see a lot of these deformities on a pre-fight exam. Most of the fractures are 4th and 5th metacarpals due to the motion at the carpometacarpal joint. There's quite a bit of motion, particularly with the 5th. Some with the 4th. The column, the rigid column, is through the 2nd and 3rd CMCs, and that's why punching technique concentrates on using that column as your weapon, and not the 4th and 5th metacarpals. So fist position at point of impact is critical. Know where the snuff box is located and check for that. Pre-fight, you can make that part of your pre-fight routine. Certainly, if there's a suspicion of fracture, splint triage. Also, I would get in the habit of just in a pre-fight exam, get used to palpating the wrist, feel the wrists. Quite often, if there's an injury, there's quite a bit of swelling, and you're really not going to see any gross deformity. It's really going to be determined based on your clinical exam. And these are the two that you want to be aware of. There's going to be quite a bit of swelling, and you're not going to see much deformity, but you don't want to miss this, so get used to feeling what normal is in this column. Radius, lunate, capitate. This is a straight lunate dislocation, and this is what's called a perilunate dislocation between the lunate and the capitate. You won't be able to reduce these, but you need to be aware of them so that you can make an appropriate decision on whether the fighter can continue. Radial head fracture, any injury on an outstretched arm should alert you to elbow injuries. The easy thing about this injury is you can put your finger directly on the proximal radius on the radial head, and you can, pronation, with pronation and supination, you can palpate the entire radius, practically the entire radius of the radial head. So in some asthenic individual, you can practice that and practice palpating the radial head and assessing it for tenderness and crepitation, and as well as lost motion. This is the supracondylar fracture I mentioned earlier. The differential diagnosis between this and a dislocation, it may look the same, but if you palpate the olecranon and the epicondyles with a fracture, they all go together. So don't confuse a dislocation. Check the olecranon to epicondyles and splint and triage as needed. Thank you.